Yeah. Okay.
All right, guys. I'm Reegan Delzer. I'm one of the new PTs. I started here in June. Hopefully you all can hear me. Obviously, that's not going to work. So I'm going to try to be really loud. It's not my strong suit. So I moved here again in June. I'm married to my husband, Jeremiah. We live in Sanborn. He's a teacher and a football coach and a track coach. So we're busy. And then I'm also pregnant. Yeah. Okay. So, what is dry needling? So, it's a technique that we use. It uses a small monofilament needle to treat dysfunction in a muscle. You don't inject anything, so that's why the muscle is a lot smaller than the one you're used to having shots or drawing blood. It's really, really thin. We aim it towards trigger points, which we'll talk about later, kind of what that looks like. And then it works to increase blood flow and decrease inflammation. Electrical stimulation is also used alongside dry needling. It's not for every patient, but we do it for probably about 80 to 90%. So diagnosis is treated with dry needling. There's a lot, and these are just the ones I tend to focus with. So like it shows shoulder pain, rotator cuff pain, biceps tendonitis, tennis elbow, golfer's elbow, whiplash, headaches, neck pain, back pain, sciatica, IT band syndrome, shin splints, Achilles tendonitis, plantar fasciitis, and more. There's a lot more. I'm only certified in level 1 dry needling, but there are more levels, and that leads to more diagnoses. So a trigger point, like we talked about earlier. So it is a hyper-irritable spot in a tight muscle band that can refer pain to other areas. And we have more slides up next that will show a lot of trigger point referral patterns. But as muscles are tight, they come banded just like this. Let me try. So they create like a little ball. And then that causes pain and refers pain, and it's different based on wherever that's at. So they impair blood flow because the circulation can't get to that muscle band, and it reduces supply of oxygen, calcium, and other nutrients that's necessary to relax a muscle, but it's also necessary for healing. Inserting a needle into the trigger point can elicit a local twitch response, and that's what we're shooting for because it's shown a twitch response will improve fiber orientation. Yeah. So let's go back and look at the piriformis. I'm sure a lot of you have heard of like piriformis syndrome. Maybe you have, maybe you haven't, but it's a big muscle that's kind of right along your backside, and it attaches from the low part of your spine over to your hip, and it can cause that referral pain right here. It's down here, and it goes down the back of the knee. And so this is a common one that we'll use with the needle. The sciatic nerve goes through the piriformis, over it, or under it. It just depends on the person. And so we are very cautious of that, obviously, but the needle is so small, it doesn't really bother it. And I also know where the sciatic nerve lives, so we're pretty safe with that. So next is the lat. This is a muscle on the back side of your shoulder blade, and it's often called like the toilet paper muscle because it wraps over to the back side of your shoulder. And so it starts right here at that bottom portion of your shoulder blade, and then you can get referral all the way down the arm into like your pinky area. And then this is another way. See how it goes into the front of the shoulder and then down the side, because it actually will come and attach down at your hip. So this is a really big muscle that can cause a lot of pain for people. Especially athletes, just because they're stretching and using their arms above their heads a lot. So this next one, you can't really see it, but it's called the semispinalis capitis. It's a neck muscle. The semispinalis actually runs the whole length of the spine, but capitis just means going to the head. And so this one has a referral pattern directly on top of the head, and you can get pain right there. So a lot of people say they have a headache right here, and that's telling me that's the muscle that I need to treat. Then upper trap, everyone's probably knows this guy. It's that big one that sits on top of your shoulder blade. It's huge. It attaches down your spine to about midway, like about here, and then it goes to the base of your head. And so you can get referral patterns to the eye, which is a lot of times people have headaches that go to their eye, and this is a big contributor, this muscle. And it goes down the neck. It also attaches here at the jaw, so they'll have jaw pain with this one too. And so it's a really big muscle that we have to treat a lot in physical therapy, and we also treat it with dry needling. So then the next one we're going to look at is your brachioradialis. It's a big muscle that we'll show today actually. And it attaches kind of above the elbow and it goes down into the thumb. So you have pain right here. There's a thing called your snuff box. And it's a bony structure, and so you can get pain right in here between your thumb and your first finger. Okay, so more like looking at the leg again. So the soleus is a muscle that lies underneath, like, it's part of your calf musculature. And this one will have pain going straight to your heel. So a lot of people have heel pain, and this is one that I'll treat for that. It's pretty deep. And it also will go up to the spine, and this is just based off of like nerves. It doesn't have it, like the soleus doesn't have any attachments above the knee, but because it shares a nerve, it will travel up there. So then the glute med. This is a big one for walking. If you've had me as your physical therapist, I've probably said this a lot, this muscle. But it is on that side of the hip, and you'll have pain that goes up into that low part of that back, and then it'll go down the leg a little bit. And then the glute min is actually underneath the glute med. And this one will send pain down the side of the leg, like almost to the knee. So we also treat that one there. And then more. So peroneals. This is a muscle on the side of your leg, and you'll get pain into that, like outside of your foot region. So this is a big one for athletes again when they get lateral ankle sprains. We'll treat this. And then we've got your quads. So there's a lot more quads than you think. There's more. And one of them is your rectus femoris, and that's the big one that will give pain right over that kneecap. And then you've got your medialis, and that gives you medial knee pain. And so this is a big one to treat after like an ACL injury. And then vastus intermedius is deep to the rectus femoris. And then your vastus lateralis is that outside of the knee pain. It'll go from the top of the hip all the way down to the outside of the knee. So, how dry needling works. When you get a tight muscle from an injury, from overuse, from underuse, it will lead to a sustained muscle contraction. You might think because it's weak that it's not maintaining a contraction, but actually can do the opposite. And then that sustained muscle contraction will lead to a damaged tissue. And those will increase the release of inflammatory substances, and all those inflammatory substances, there's a lot, I won't really say all of them, but they'll like continue to relay pain signals to the brain. They start in the periphery and it will go to the brain. So our goal is always to get rid of those with dry needling because it just continues to cause issues. So this is an image that they took of a muscle underneath a stethoscope. Not a stethoscope, but yeah. So top image is a normal muscle band. As you can see, there's a lot of space between, so that's where like blood flow through, oxygen, all the things, and then the bottom is where the muscle band is really tight, and there's not any space, any gapping. And so, like, this is the same part of the muscle as here. This is, I think it's part of your hamstring, is this, they took this from, but, so there's gonna be lots of problems with this lower muscle here compared to this one, because they're not traveling through, oxygen isn't going through, and nutrients aren't going through. So, a lot of you are probably thinking, dry needling, so that's acupuncture, right? Acupuncture is different. It's a lot older than dry needling. It's based on the theory that injury or dysfunction occurs to blockages in chi, which is their word for energy. So again, it's an Eastern medicine type treatment. It's been around for thousands and thousands of years. Their knowledge is different than what I've learned in school, so it's worked for a lot of people. I just don't know too much about it because we don't get taught about it. So they work to aim to restore energy flow and return to a state of balance. These are meridians, and they try to treat based off of energy meridians. But my knowledge is definitely different. We learn based off of muscles and all those referral patterns, so I treat based off of muscles and what I know. So that's the difference there. If you have any more questions, you can ask later. So origins of dry needling. In 1940, there were two physicians, Janet Travell and David Simons. This is Janet Travell. She proposed that injecting myofascial trigger points could help relieve pain. And they were injecting things into it and not using just a regular needle. They were injecting corticosteroids. Analgesics is just like pain reliever, and then saline. So that's like a placebo. So Janet Travell actually became the White House physician under President John F. Kennedy. So these are pretty well-known doctors. And then later on, in 1979, Karol Lewitt, he was a Czech physician. He published a study where he used dry needles and placed them into trigger points and found that patients still experienced pain relief even though nothing was injected into the tissue. So he's kind of the guy that started all of the dry needling movement. So obviously 1979 is not that long ago. And there's a lot of evidence coming out, but it's not as extensive as other treatments. Okay, so dry needling with electrical stimulation. An electrical current is conducted through the needles into the muscles to improve function of the muscle and decrease pain. Studies find that physical therapy with dry needling leads to long-term reductions of pain, more than just pistoning, which is when you put the needle in and out of the tissue. And it can be used for up to 20 minutes with the 3-channel system, which is this top one. And then this is the pointer system, and that can feel a little bit more intense, so I only do that for about 30 to 90 seconds. But your first session, you won't be as used to it, so we won't ever really go up to that 20-minute mark. That's only with my athletes that I know their muscles are functioning and we're trying to get them back to play. So 20 minutes is rare. I won't really ever do that. You'll get really sore after that. So what to expect at your appointment. Wear comfortable, loose-fitting clothes to allow access to the area that needs treatment. skin will be cleaned where the needles are inserted. They're inserted into trigger points, so before therapy I'll do a lot of palpation. It's just me feeling around on the muscle, trying to decide where exactly I'm going to treat. You may or may not feel the insertion of the needle. Discomfort is minimal with the insertion of the needle because it's just so thin. You might feel like a little zing just because of a cutaneous nerve or a cutaneous artery. And then you will feel a deep ache as the muscle or the needle goes deeper into the muscle. And then another thing is dry needling is not yet covered by insurance. As we talked about, that dry needling is very, very new. So especially going into, which we'll talk about later, some different diagnoses, there's not a lot of research based on specific things. Like we're going to talk about neuropathy and fibromyalgia. So there's some coming out, but it's still so rare, especially because a lot of those diagnoses haven't been around for long either. They're all still new. So they're working on it, but because it's not covered by insurance, it's $40 at each session when dry needling is used. I only do dry needling once a week max. So you may experience soreness, slight bleeding, and bruising. So what to do after dry needling? Drinking water is huge because it helps flush out those toxins that we were talking about that all get put in your system from those pain. And so those are released during dry needling and we need to get them out of your system, so that's huge with water. And then light physical activity. You don't just want to sit and do nothing because then the muscles will just tighten right back up again. But you also don't want to do like an intense workout, like run 3 miles or squat 100 pounds 300 times, something like that. Ice versus heat. So people often come to me with that question. Ice is not bad, ice is good, but sometimes ice isn't the best for everyone, and same thing for heat. So I like using heat following dry needling because it keeps increasing the blood flow, where ice will stiffen that tissue back up and stop the blood flow from going, and I want the blood flow to keep pushing everything out. So I prefer heat pack over ice, but that's my knowledge. So again, the research. We'll start with fibromyalgia. This is just a common one that a lot of people are getting diagnosed with. So this study was a case study that was conducted to evaluate the short-term efficiency of dry needling therapy in patients severely affected by fibromyalgia. Weekly 1-hour sessions of dry needling were done for 6 weeks. Dry needling showed significant decreases in pain, fatigue, and a couple other questionnaires that we don't have to go through that are all like based off of research. 6 weeks post-treatment, dry needling showed significant differences in all of the tests that they used. Upper quarter myofascial pain syndrome. So that upper quarter just means neck, shoulders, arms. Based on the best current available evidence, which is grade A, we recommend dry needling compared to sham or placebo for decreasing pain immediately after treatment, and at 4 weeks in patients with upper quarter myofascial pain syndrome. Due to the small number of RCTs, they continue to need more research, but again, this is that saying that it's hard to find specific diagnoses and a lot of research behind it just because dry needling is still so new. Headaches, dry needling, for this one I found like it was an RCT, but and a case report, but dry needling was associated with improvements in pain and range of motion and muscle function. So in this group, they needled the upper trap, that's that big muscle that we talked about earlier, suboccipitals, which is like in the back of your head, at the base of your skull, and then your SCM, which is a muscle like right here in the front of your neck. And they had a control group, which was just receiving physical therapy, a dry needling group, which got dry needling and physical therapy, and then a placebo needling group. So they had physical therapy, and then they were needling as well, but they were doing a superficial needling. So they weren't going into the muscles at all, and they were away from any trigger points. So they assessed the outcomes of pain, which they looked at pain and range of motion and muscle function. And immediately after 3 months, 1 month, 3 months, and 6 months, they found that headache intensity and neck disability decreased significantly more in the dry needling group compared to the placebo group and the control group after the treatment session, immediately after, and then during all of the follow-ups. So they found that the frequency of headaches also reduced more in the dry needling group than in controls and the placebo group, but it was not entirely statistically significant. And that just means like it's a long story, but it's a p-value. So they also found higher cervical range of motion and enhancement of deep cervical flexors performance was also observed in the dry needling group compared to the other groups. So they found a lot of things, but again, just because the study size is so small and they're not doing a ton of research, they're not finding a lot. Neuropathy. So this is one I got an email about, so I really wanted to include this in. Neuropathy is very common, especially with diabetes. It's where you get that numbness and tingling and in the lower, normally it's in your feet or like starts from your shin down, but you can get it in your hands too. So this one was for diabetic neuropathy. It was a case report, so there was only one patient. So again, they used dry needling with the E-stem, and it was targeted alongside the sciatic nerve distribution. So that is going from the top of your hip down the back of your leg. They had 4 visits over 5 weeks, and they found that sharp, dull sensation testing improved in from getting 2 out of 5 correct. So when you're doing a sharp, dull test, and you'll get this in the doctor's office, it's like a little pinpoint prick for the sharp, and then the dull one is like a cotton ball, and they poke it, and then you say if you feel it, and then or not, or you just don't say anything. So out of 5 spots, before the treatment, he was only saying he felt 2 of them, and that was on the left leg, and then afterwards he improved to 5 out of 5, and then on the right leg he had 2 out of 5 again, and then improved to 5 out of 5. So those improved, but again, only 1 patient. Contraindications to dry needling. So active skin lesions, active cancer, if you're immunocompromised, blood clotting disorders, first trimester pregnancy, areas with lymphedema, and severe needle phobia. If you have a severe needle phobia, I just won't do it, because if you're going to be scared of it anyway, like it's just going to affect your treatment result, and I don't want to cause anyone trauma. Also with like the active cancer, and with first trimester pregnancy, just research isn't done on people with those conditions, so we just keep them out of it just because it increases risk of infection, and you don't want to be told you caused miscarriage or increased their cancer, even though it could have been totally not related. You just kind of keep those people out, so that's why it's a contraindication. Precautions would be like 2nd and 3rd trimester pregnancy, so I wouldn't needle my back now. I mean, I'm like 6 months pregnant, so I wouldn't needle my back just because of the position of my baby, or I can also needle abdominals later on, and I wouldn't do that. So I could needle my shoulder because it's far away. So again, it's a precaution, and it's something you would talk about with your doctor or your physical therapist. And then blood thinners are also a precaution. I'm more concerned with like warfarin or heparin or Eliquis versus like, I don't know, everyone always is taking a baby aspirin, so it's a little different. But it's more of a precaution, and I'd want to speak with their doctor about it before we would continue with therapy or dry needling. And then another thing I want to talk about is like a total knee or like a total hip. You can do dry needling with like a total joint surgery 6 weeks following, but you want to do it like separate. So if someone had their knee replaced, I could needle their shoulder because it has a different vasculature, but I would wait a full 12 weeks to needle their knee because it would be the same, just to like be really sure you're clear of that infection period. Okay, so we're gonna do a demo. If I could have Abby come up. We're gonna go in the middle so you guys can all kind of see.
Don't hit me. No, jerk.
Oops. Okay, which arm do you want? Okay. So I'm gonna have her set her arm here, and I'll move this stuff to the ground so you guys can hopefully see. So again, it's a very clean process. I'm gonna put the gloves on. And again, if you're afraid of needles, just don't look. And then we're gonna clean the skin. So what I'm gonna do for Abby here is her extensors. So if she raises her wrist like this and pushes my hand, push my hand here. Yeah, it's all of these muscles here. So tennis elbow is something that can happen when you get pain on this outside of your elbow here. So this is one we will do a lot for that.
All those pickleball injuries.
Pickleball injuries. Yeah.
Can we set that down?
Oh, what?
Can we set that down?
Yes, we can set it down. I'll move it in a second.
Thank you.
Yes.
They look longer than acupuncture needles.
They're what?
They look longer than acupuncture.
So yeah, that's another thing. There's lots of different sizes. So there's this size compared to this size. This would be like for a glute. This is for the forearm or the shoulder. Okay. So again, I'm gonna, is that sore?
A little bit, yeah.
Okay. So this is a common spot for a lot of people to have pain here. So I'm pushing down on the muscle, on the tight band that I'm feeling. It feels like a trigger point. It's really hard compared to our other tissue over here. And I'm gonna pull apart my fingers, and then I bring the needle in here, do a little, gotta undo this. There's a lot of safety mechanisms. And then I'll do a tap. And then the needle just goes directly down. And she had a twitch right away, which is common, so that's good. We're gonna show a couple different options. So this is that pointer system. This is a ground. So I'll put the needle here. Again, watch her fingers, okay? If you can see, hopefully you guys can see. So
Control it.
this one is in her extensor carpi radialis brevis because it's causing her middle finger to jump. This is one of the main causes of tennis elbow. So the needle is also moving as well as her finger. Okay, so that's one way. Then I'll put in another needle and we'll do the other system. gonna shoot for over here.
How deep does she go?
It depends on the muscle. That's a great question. She just asked how deep does or do I go with the needle? And it really depends on where I'm at. With this one, I'm going towards the bone. So this is at her ulna right now. This is kind of near her radius. In the quad, so like if I was doing that, it depends on what muscle I'm doing, but I can go all the way to the femur, or I don't have to. It depends on which muscle again. And then, yeah. And then in the glutes, I need that long one because I'm going all the way to the pelvic bone, so the ilium. Yeah. So this one I'm putting on a different one. This system I can do up to 6 needles with, but right now we're just obviously just gonna do 2.
So what are you feeling, Abby? I mean, are you?
Kind of, if you've ever had like electrical stimulation, it's like kind of like a buzzing feeling.
Like a little zing?
I didn't feel anything when she first inserted it, but as she like twisted it into the muscle, you just kind of feel a little pressure.
That pressure. You don't feel faint?
So this one is a little bit of a different strength than this one. So we'll see when it will start. Do you feel anything yet, Abby?
Yep, right there.
Okay. So the needle is moving on both of them. And they're moving kind of together, but obviously with the other one, it has a lot more strength, so her finger was moving. And we can crank it, but we won't crank it too much. Yeah.
Switching together.
So what I'm looking for when I'm doing stem is I'm looking for a symmetrical contraction of the muscle. And often I'll find that one will be working and the other won't be. And I can't get them to work together as a unit. So that's showing me a little bit of dysfunction. If one is going kind of crazy and the other one's small, that's showing me there's dysfunction. If one is going here and then not going for a while, then going, and then not going for a while, that's telling me there's dysfunction. So this one, there's a light on here that'll blink, and that's how it should be beeping. It should be moving along with this light. And if it's not, then I know there's dysfunction in that muscle. So this is the system that I could leave on for 20 minutes if I wanted to, but I won't. She'll be pretty tired, so I will turn it all the way off before I take out everything.
I have to play volleyball tonight.
Oh, yeah. Her right arm is going to be a powerhouse. So again, she can experience some soreness, but and Abby didn't have a lot of problems before she came in here today. So she likely won't feel too different. But if you are coming in with a soreness, you can often feel like immediate relief afterwards or immediate soreness. So it really just depends on the person, and it changes every time. So there's the needle.
Don't even feel.
There's the needle. And you can get slight bleeding. She doesn't, but I'm just gonna, you rub the tissue afterwards to try to like calm it down. And then she's good. So that's that. Okay, so we're gonna move everything back and then we'll take time for questions. No, so her question was asking if Medicare pays, and no, they don't. So what we do is when we have you come in, we have you sign like a consent form and make you very well known about this. Like, I'm not going to do it and then say, okay, you owe me $40. So I'll let you know far in advance, give you time to make a decision. We also fill out, it's called an ABN, so it's an advanced beneficiary notice that we have you sign, and then we'll also have our billing department involved, and we still work on billing it to kind of show the need, but no, it's not covered.
Does it have to be doctor recommended?
So, no, for physical therapy itself in this facility, we are not direct access. We have to have a physician order for you to come to physical therapy. So, it doesn't have to be doctor ordered for me to recommend dry needling though. Oftentimes doctors will come in with that in mind already when they send me a patient, and it'll just say dry needling on it. But no. And if there are any questions when I'm looking through like your medical history, then I'll be in contact with you and your doctor about if dry needling would be right. Yes.
Is this anything related to reflexology? Did you ever have to study that at all?
No, so I do know about, her question was, is this related to reflexology? And reflexology, it's where they put needles in the foot, right? Or where they do massage to the foot.
Yeah, it's more massage. I don't think they use needles.
Yeah, it's not needles. Yeah, it's not needles, it's just massage to the foot. I know one, actually. But that's more based off of Eastern medicine again, I believe. So I don't know too much about it, but I think it's based on a specific trigger point in the foot can relate to pain somewhere else. But no, we don't.
It's not just the foot, they can use the hand.
Hands, yeah. I haven't been taught about that in school though. Yeah, they go to school for that separately. Yes.
What kind of training and where did you get trained?
Yes, she asked what kind of training I have. So again, I went to physical therapy school. I have my doctorate in physical therapy. And then after that is when I go to a class for this. So there's lots of different companies that are offering it. And I have, every one of my clinicals that I went to when I was a student, there was a physical therapist on the site that did dry needling. And each of them went to a different course, actually. So I picked which one I felt like worked the best. To me, this was the one that I chose. So I have found the most benefit when you apply electrical stimulation with it. And there's some techniques that just use pistoning, which is bringing the needle in and out of the muscle and moving it around. And that does really well too. But I just found that stem is more tolerable to the patient instead of moving it in and out. It can be kind of uncomfortable. So I wanted to do one that focused on that. And so I reached out to a couple of different people that I knew did that, and I applied for that course. My course specifically was a 3-day course that I went to in person in Omaha, but there was a lot of stuff that I did online for a month prior. I watched a lot of videos and did all the coursework, took a lot of exams, so yeah. Any other questions? Yes.
So when you're doing a treatment, and let's say me, fibromyalgia, chronic fatigue, myofascial pain syndrome, and I lived closer to Omaha years ago, and I would go in. He was a osteopath, and I would go in and I'd get trigger point injections, and those were not fun. But you get to the point where you got to do something. So if you're working with somebody like that, I mean, do you develop like a whole plan for that individual and these things that are going on at the same time in your body? I mean, how do you focus between those things and like, I have back problems and my sacrum is shot, and how do you figure that
Yeah, so her question was more just like, how do I make like an individualized plan? Because I'm not going into it, oh, they have back pain, I'm going to treat this specific muscle because it is at the back or attaches at the back. I take the whole thing into consideration. So again, fibromyalgia is a huge disease process that a lot of people are having and is becoming more common. And I'm gonna look into that beforehand and just see how they respond. So one thing is, do they respond well to me working on their muscles with my hands? So doing manual therapy. Do they respond well to strengthening? And just, do they respond well to electrical stimulation? Do they respond well to ultrasound? And what kind of works for them? And oftentimes, I'm not needling you your first visit. It's gonna be down the road. Or it just depends on the person. And I'm constantly going through that and changing my thing based off of how they're presenting, and I'm developing a caseload or like a plan of care as I'm going. I always have dry needling in the back of my mind, just like I always have scraping or manual therapy or PNF. There's a lot of different things that we utilize as therapists, and so I always have these tools, but I'm not always going to throw them all at them at the same time. So I'm taking my time and making sure each thing is right for the patient, and the more you get to know them, the more you see them, the more you realize what muscle is actually dysfunctional, and you kind of learn how they're going to respond to a specific treatment. Yes.
So does Medicare pay for the prior visits that is under physical therapy?
Yeah, and so her question was, does dry needling pay for the visits prior to physical therapy?
Does Medicare pay for the prior visits that you're doing physical therapy on?
Yeah, and they pay for the visits following, too. They just won't pay for the specific portion of dry needling, and so that's why it's $40 after
Per
that.
session?
Per session whenever I do it. Doesn't matter how many needles I use.
What's the most number of needles you would use in a session?
It depends on the person again. I don't think I've used more than 6. Normally 2 to 4. Yeah. You don't want to, and I don't do that right away. With someone I would do the first time, I'm only using 2 needles max, unless I know that their tolerance is going to be okay. And then I'll progress them, because otherwise they're just going to get too sore, and I don't want them to come back just being like, I couldn't move for how long. Yeah.
How many different sessions do you need to take? Is one session gonna help, or do you need to come back?
It depends. She asked if one session will help with physical therapy or with dry needling, or how many more sessions they would need to come for. And that again is totally patient dependent. It's how long have you been having this injury? How long have you been having back pain? Often people are coming to me for a chronic issue that they've had for years, and so then that can take a while. So like I said, dry needling can help increase muscle function and those muscle fiber recruitment. And so that can take a while if they haven't been using those muscles or if they've been dysfunctional for years. So I'm not saying you need to come to physical therapy for the rest of your life. That's never the thing. But I will make up a treatment plan of like 4 to 12 weeks, and we'll see how it goes. And if we need to adjust that as we go, then we adjust it. And it just depends on the person. If you have a more acute injury, like they just sprained their ankle yesterday, then results are quicker.